Okay, here we go.
All right, and let me write this down, so because I'm gonna forget this when you tell me. All right, so it's SE.
Welcome, everybody. We're about to get started. It's nice to see so many people and so many names. We don't get to see enough of the people, but we've got lots and lots of names. So, Margaret, why don't you start with introductions?
Sure. So welcome. And as you know, we have a Rhode Island state membership meeting today, and we have a leadership team that three of whom are here today. And so I'm going to start by asking them to introduce themselves, and we'll start with Elizabeth.
Hi, everyone. Welcome. My name is Elizabeth Marrera. I'm a healthcare administrator currently coordinating LISC's Pawtucket Central Falls Health Equity Zone. I'm a director of operations of Project Health CV and also a proud board member of Primary Care for All Americans. And I pass it over to Paul.
Thank you. Paul George, I'm a primary care doc in Woonsocket, and I'll pass it over to Dr. Gutman. Sorry, Dr. Gutman.
Hi, this is Josh Gutman. I'm semi-retired family physician from Providence, and happy to be here with you all.
Okay, and Michael, will you give us an update on PC4AA activities nationwide and in Rhode Island?
Sure. Thank you. Welcome, everybody. Primary Care for All Americans, you'll remember, is an organization that exists to build a social movement to create a healthcare system that's for people, not for profit, and starts by providing primary care to everyone in every neighborhood and community. We walk on two legs. One is the leg of state work groups, of which this is one, and the other is the leg of local work groups. We now have 3 active state work groups, one in Rhode Island, one in Massachusetts, and one in New York, with new state work groups forming in Maine, Colorado, and Texas, and probably a couple of more on the way. We have one active, or really now 2 active local work groups in Rhode Island, one in Central Falls and one in Situate, with other work groups on the drawing board for Woonsocket and Newport. Local work groups try to focus on getting everyone in their own community into a primary care relationship, and on building the capacity, the workforce that's needed to do that. State work groups in general have focused on three areas. One is on measuring the percent of the population that's involved in a primary care relationship. The second is on workforce, because the primary care workforce is in desperate trouble. So expanding workforce by building new slots in medical schools and nurse practitioner schools, building new residency programs, and creating scholarship programs, as well as loan repayment, so people from our communities can afford to go to medical school. And the third major area that state work groups have been focusing on is reimbursement reform, particularly under Medicaid, to try to get Medicaid off fee-for-service and onto subscription-based payment, so that practices can afford to be the multidisciplinary teams we need them to be. And we'll talk a little bit later about where we are in Rhode Island from a legislative perspective. We've actually had a fair amount of impact already, but I think first we wanted to spend some time hearing everybody's stories. Elizabeth, you want to take us through that?
Thank you. Yes, so we kind of wanted to learn a little bit about who we have in the room and just kind of understanding what what brought you to this meeting. So we have some prompting questions, like what's on your mind, what brought you here tonight, what are your priorities, and if there are any questions that you may have for the leadership team, we're definitely here and willing to facilitate that. I do see some people are off camera, which is fine if you want to put in your question into the chat, or if you want to hop off mute. And if you want to use the raise hand function on Zoom, just so we can coordinate across that. But what's on your mind today? What brought you to this meeting, and what are your priorities? And I want to call in on anyone. Do we have anyone to volunteer to speak? I see David may have gotten off mute.
I'm off. Hi, I've been working with primary care since the 1960s. I fought in the war on poverty. It was in Boston when they created the first neighborhood health center. I'm senior vice president of the teaching hospital, helped start a medical school that emphasized primary care. I go to the VA for my medical care and out in the private practice, and primary care people don't make enough money. So that's in mental health, obstetrics, gynecology, pediatrics, general practice. So now we're leveraging down to nurse practitioners and PAs. We've destroyed the public health system. So I want to learn how I can help at least develop something in Rhode Island, which is in terrible shape. My 50-year-old daughter was in a practice for a number of years, and the physician left. So I don't know where he went, tired of it, I guess. She has yet to find a new primary care doctor. So there we are. And it's rich people, poor people, and those of us in between. And so I'm willing to get involved with somebody. Here in Rhode Island, we got a mess with our hospitals. We got a mess in Boston. I was involved with the Caritas Christi Health System before it became Stewart, before it became an albatross around everybody's neck. So if there's somebody in Rhode Island that'd like to work with me, I'd work with them to see if there's at least we can do one center where we can take care of, help a few people. There you go. I've
David,
done
we're
it
going to
all.
put you to work.
I've done it all. Are you Dr. Fine?
I am.
Dr. Fine, my friend Vin Marzullo speaks of you all the time, and we've never connected. I've been here for several years, but I'd like to work with you because there has to be something in the prisons, in the street, in North Kingstown where I live. It's like a no man's land down here.
We come to the right place.
Okay,
Thanks
so
for-
you got my contact information and just get in touch.
Thanks for joining us, but hang on. We've got a bunch of stuff to do. We're going to put you to work today.
Okay.
So just hang on. We're going to hear from a couple of other people perhaps, and then we'll talk about what we're doing in Rhode Island today.
Yes, and Margaret
Right.
did just put in the chat, if you'd like to put your narrative in the chat, we'll read from the chat. But also if you'd like to get off mute to share what brought you here, please do so. Fred, did you want to speak? I see you're off mute.
Oh, well, I'm a specialist and a retired specialist at that, recently retired. So I don't know exactly how I can help, other than the fact that I agree with everything that Dr. Fine is saying about what's wrong with the system. And I think the corporatization of medicine has gone far beyond what it ever should have. And Obamacare unwittingly, I think, or unwittingly made it all worse. And we just got to unravel it, and we got to have enough primary care physicians scattered throughout Rhode Island and scattered throughout New Hampshire and Maine and all those nice places where they need primary care. And I don't have a absolute prescription for what to do, but I'm interested. And I'm here in Rhode Island. I've got some time on my hands that I didn't used to have, and I really want to help the best I can.
Hi, Fred.
Hi.
Thanks for sharing. Anyone else want to provide an introduction? Hi, Marie.
Hi, so I'm a friend of Dr. Find.
Way more than that.
For a long time. I was a former health insurance commissioner for the state of Rhode Island. But even before that, I was a real believer that primary care is the foundation of our healthcare system. But then in the Rhode Island Office of the Health Insurance Commissioner, of course, that's like one of our primary tenets. And we spent a lot of time working on primary care medical homes and ensuring that the insurers supported those. And now I see that a lot of that work is crumbling with the shortage of primary care docs, and there are lots of things that we can do. So I had formerly worked for the legislature for years. I have some experience there and still some contacts, a few left behind. So whatever I can do to help. I'm not a provider, so unfortunately I can't, like the rest of you, say I'm gonna, volunteer my time or whatever, but I'll do whatever I can with whatever expertise I have.
Thank you so much
Advocacy
for
is a
being
big-
here.
Big component, so we'll definitely need some of your legislative contacts and specialties. So, anyone else like to share? I don't want to call out names, so put anyone on the spot. But if something comes up and you want to share, please feel free to use the chat. I know sometimes some people are in transit or not able to get off of mute right now, but there'll definitely be opportunities for you to share your perspective. Let us know who you are and why you're here today.
Can I just, for a second, introduce Lynn Blanchette, who's not on the call, but is a great nurse and nurse teacher. She's the state's expert on community nursing. She's one of the leadership groups. She couldn't be with us today, but she'll be back with us the next time we meet. Josh, you want to talk about the work plan?
The piece of this that appealed to me right off the bat was one of the things you mentioned in the introduction, to try to establish some form of objective baseline of primary care affiliation among the population of Rhode Island. And I was having a difficult time conceiving of how to do that until you mentioned this database that the state has for all of the significant health insurers in the state. And the question was, could we use the data to pinpoint the numbers of people who demonstrate a primary care relationship, perhaps by who's had preventive health visits. I did briefly look at the site Health Facts RI, and they have not provided much data, and the questions that they've tried to answer don't reflect our needs at all. So I will have to contact someone involved to see what is involved in obtaining the kinds of data we want. And I certainly would encourage anyone who's here who has some math data expertise to collaborate in this, because if we can develop a measure, percent of Rhode Islanders with a primary care relationship, then we can use that year to year to determine whether we're making progress in everything else we're trying to do. The second item on our agenda was to get it in terms of recruitment and retention of primary care people, to learn about scholarships and loan repayment programs. And I looked in all the wrong places until I found Dr. Paul George, who provided us with a rather excellent list of things that he knows of that are available in Rhode Island, and gives us a starting point to try to improve our what we can provide.
Sure, and thank you for that. Yeah, I mean, so there's a number of different options for loan repayment. This is not an exhaustive list by any stretch. The two that are Rhode Island specific, and many of you have probably heard of these already. So there's the Rhode Island Health Professional Loan Repayment Program, which right now is actually encouraging applications as we speak. And it encourages healthcare professionals to work in medically underserved areas. And so it can be physicians or NPs or PAs. The key here is that folks who are eligible must work in a HIPSA. So we've got HIPSAs all over the state. Where I'm in Woonsocket, they're in Pawtucket and Central Falls and Newport and Providence. And so lots of different areas, but really the FQHCs are the main place that you can fulfill this requirement. You can get up to $50,000 in loan repayment over a 2-year period, and they're renewable until your loans are paid off. And you have to commit to at least 2 years in an eligible healthcare facility. Like I said, primarily FQHCs. There's also the Wavemaker Fellowship, which has been around for the last couple of years. It's different in that it's not a loan repayment program, it's a tax credit. And it's not exclusive just to healthcare. So folks can be in STEM, education, et cetera. And depending on what level your degree is at, you can get up to a certain amount in tax credits. And those tax credits are available for up to 4 years. And there's other loan repayment options too. So there's the public service loan forgiveness, which I actually benefited from and had my loans forgiven through that. That requires 10 years in a nonprofit. There's the National Health Service Corps, the Indian Health Services, et cetera. So there's other options too, but these are the two Rhode Island specific options that are available right now.
Thanks, Paul.
Can I speak to two experiences I have? My wife and I have been a customer of Leahy Clinic in Boston, Burlington, Massachusetts, for 40 years. And it was built around the notion of a multi-specialty group practice. Have some experience with that. So what I've noticed in the last 10 years, there are no residencies in primary care practice at Leahy Clinic. There's no residents. They've switched their affiliation to the University of Mass Medical Center. And my primary care doctor, if I really put the arm on him, I can see him every 2 years. Otherwise, I get leveraged out to urgent care and nurse practitioner. Okay, that's number one. Number two, I go to the VA. I'm a veteran. I have a disability. I have gone to the Veterans VA Hospital in Bedford, Massachusetts, Boston, and here in Providence now. We've lived here 6 years, only going on 7. I used to get primary care doctor visits more often, and now they're getting longer. Number one, you have urgent care, you have an emergency department. I meet residents of the medical school that we helped to create in New Jersey in the 1980s. They're all in specialties. They're coming in through the medical school of Brown, and they're in dermatology, hematology, you get the others. Or I have a glaucoma, so they're in retinal and glaucoma. I don't see any primary care coming into that vehicle. And what I learned back in the 60s and 70s, 80s, that people went to practice where they did the residencies. And then I talked to these young people and they're doing their residencies. They're not going to stay here because they make more money in Massachusetts or someplace else.
Let me tell you what.
The economics is brutal.
Let me tell you a little bit about the workforce numbers, which we know something about. So, and you're right that 60% of people, or 60% of people who finish residency will practice where they finish residency, particularly in primary care. And what matters for us is primary care. At the end of the day, because primary care is the only medical service that's ever been shown to be associated with improvements in public health outcomes and the reduction of cost.
Right.
But we in the United States have 66,000 students a year apply to medical school. There are about 125 of those are from Rhode Island. Of the 66,000 who apply, 22,000 get in. In Rhode Island, probably in a typical year, about 60 get in. We do actually pretty well. But in Rhode Island, usually only 6 to 10 get to go to medical school in Rhode Island. So we lose them out of the state right up front.
Yeah.
Of the 22,000 people who graduate each year from medical school, now only about 20% or 4,400 will choose primary care. And the reasons for that are myriad, but there's a real challenge there. All residencies are funded by CMS, by Medicaid, by
Right.
Medicare.
Medicare.
And could we require as a nation that 50% of the residency funding be devoted to primary care? We could, but we don't. And I suspect part of the reason we don't is that we don't have any sort of public expression of the need for primary care, and that has sort of loosened the pressure. As a state, we could do a bunch of things. And Paul knows this as well as anybody. We could start funding our own residency programs. There's something called teaching health centers, so we could help fund those. We could help fund residency programs for nurse practitioners and PAs, so they're better equipped. We could, Paul gave us a great picture of loan repayment, but the people who qualify for loan repayment already took on $250,000 to $500,000 worth of debt, and they had to take that risk themselves before they knew they were going to get loan repayment. And most of us think that what's happened is that first generation kids, of immigrant families from Central Falls and Pawtucket, and Woonsocket and so forth, and Providence, that those kids don't risk going to medical school because the expense is so great. The National Health Service Corps, which Paul mentioned, used to field 1,800 people a year across the country. Now they field about 160. So the supply of people who can do that is much less, and that all adds up together. It all adds up that kids from our communities aren't going to medical school and aren't coming back here to practice primary care. As a state, we can we can take the loan repayment work, which is great, but add to it scholarships. We could create our own scholarship program, like the scholarship program that exists in the National Health Service Corps. So kids from our communities wouldn't have to worry about fronting the money and incurring $250,000 to $500,000 worth of debt. We can double or triple the size of our existing medical school. We could create a new medical school, which is under discussion at URI, and Marie has been quite helpful in thinking about that and talking about it. So there are a bunch of things we can do as a state. The opportunity is for us as a work group to get together and help the legislature understand the things that we need to do together as a state to improve that situation. And so maybe we ought to take a second. I'm kind of jumping the agenda a bit, but maybe we ought to take a second to talk a little bit about what's under consideration in the legislature and what our potential opportunities are. The legislature a year ago put together a special study commission to create a new primary care medical school at URI, which is great news. That doesn't mean it's going to get there in a second. Marie's on that commission, and so am I, with about 25 other people. But we are hoping that we're going to be able to encourage that. We think the legislature could direct state government to start doing exactly what Josh referred to, and start counting the percentage of people in the population who are involved in a robust primary care relationship using the all payer claims database or some other process. But that legislature would need to move in that direction. And the legislature could create a scholarship program, and actually tried to last year. The money didn't quite get funded, but that doesn't mean we can't come back and do it. And the legislature could continue to do what it did last year, which was begin to fund clinical teaching in primary care environments. But in order for these things to happen, the legislature has to have a better understanding of this whole primary care arena, the need and the value. And so one of the, and I need to say that Primary Care for All Americans is structured as an educational nonprofit. We can't lobby, but what we can do is educate. And we have been, we are aware that the legislature is having a special teaching day on primary care on March 3rd at 2:00. And one of the things that we thought we might do as Primary Care for All Americans is begin to encourage our legislators to go to that teaching session. There are 10 people on this Zoom, but we have a mailing list of over 100 in Rhode Island. We have a mailing list of over 1,000 across the country, but Rhode Island is 100. So what we'd like to do is encourage all of us to call our state legislators or email our state legislators and ask them to attend that teaching session. Margaret has put together some talking points, and all it takes is, and Margaret, you can probably take us through this better than I can, but we have some information that will help you look up who your state senator and state reps are. And then if you call or email them or write them and just ask them to attend, that would be a wonderful thing. If you happen to get them on the phone, there are talking points that helps you tell them simply what the value of primary care is, so that we can make effective communication. And that's our, if a bunch of us can do that, if we can get 30, 40, 50 calls made, in this legislature, we begin to have a fair amount of impact. And that's what we're hoping everybody will be willing to do together.
I can do that.
Great. Well, I
Yeah,
hope
good.
everybody can.
Can you forward the, what's on the screen right now? I don't know how to use the computer very well. And get things out, so can you forward those things to me? You have my email. I'll do
Send
it.
them by email. We're going to send them by email tomorrow.
Okay.
And we'll get started working on that. So that's one very solid, concrete thing that everybody can do. The other solid, concrete thing that everybody can do is start to think about forming local work groups. As I said, we have 2 already in Rhode Island. We'd like to see a number more. We have a playbook that, and Margaret, I hope you can send out the local playbook as well. The playbook tells you how to put a local work group together and the kinds of things that you can do will help support you. But as I said, we have one in Central Falls, one in Situate, one forming in Woonsocket as soon, and one likely forming in Newport, but one in Newport, one in North Kingston would be great. Other places would be great. It's about, really building a movement by starting with one other person and figuring out what you can do in your own community. So, thoughts, comments, criticisms, ideas?
The new CEO of AARP is a graduate of Brown. a doctor. She was at Demrick in Boston, primary care center. She's now the new CEO of AARP. Maybe through AARP Rhode Island, we can get some venture capital to help facilitate this a little bit.
We
You
would
know-
love to see that.
I think that they are a good resource, and I noticed that the AARP published in one of their publications a guide, an article about the shortage of physicians and a guide to how the elderly or older people can navigate that system. So they're aware of the workforce issue.
Yeah, but she's just taking over, and she's from up here, worked in Boston, in Rhode Island, in Roots. Maybe there's some way
It's-
to work in there.
Can you introduce us? Do you know her?
I don't know her, but I know the people. I ran for president of ARP Rhode Island. I was too radical. They wouldn't let me get the president.
Well, then you're just the right guy for what we're doing together.
So it is. Life is interesting.
It is that.
But I will, yeah, we'll find a way to get in there. He's just taking over right now. Just the lady who was there for years is resigning. One of the things I suggested when I was running for president of ARP Rhode Island is give everybody 50 and over free membership. So that you got a power block, so that you can go, when you go to the legislature, they have a lot of the legislative stuff. They kind of pat you on the head, but they don't put any money in the pot. Like,
Well, our job is to build that kind of power block, as it were, but a power block that focuses on making sure everybody in Rhode Island has primary care.
that's right. That's right.
Margaret, can you take us through some next steps and some other housekeeping so we can schedule a next meeting and do that well?
Sure. So we certainly want you to, we will be sending out the slides, we'll be sending out the call to action, give you some resources so that we can focus on that March 4th teaching session and get as many legislators and senators there. We're asking you to copy us when you send an email, and when you go to the Find Your Representative website, you'll see that it is entirely email. They don't have any phone numbers. So if you can copy us on that email, we can sort of measure our success. We'd really like you to do that. And then we can come back with another meeting either before March 4th or after March 4th. That's up to you to decide how often you want to get together in this format, and measure our success and look at our impact. So I think the next step for us is to determine how often do you want to meet? When do you want to meet? Is this a good time for folks? Just open it up for that sort of discussion. And once again, you can put it in the chat if you wish. So
Perhaps, go ahead.
I was gonna say, let's start with the time of day. Is this a good time of day for a meeting?
Me, it was good, but it was 7 o'clock in the evening. This is David speaking. I could hit it at 4, but evenings, I tried to attend a couple earlier and I couldn't.
Anybody not be able to do 4 in the afternoon? So let's keep it at 4.
So I just want to encourage anybody to come off mic and speak. Azia, I noticed you joined us a little bit late. If you have any questions about what we've been talking about, please feel free to ask and give us your opinion. Sorry, I didn't mean to put you on the spot, but I just want to make sure that you understood.
No worries. No worries. I can hear you all. I think sounds like 4 works for everybody. That's fine. I just got off a call at work, so I'm just listening in the background. I wonder if later works for people who have to work until 5, but I was able to join at least a half hour late, and this would be fine going forward.
Okay, you can keep that in mind. And then the frequency of meetings. We have that target date of March 4th for action. Should we be meeting again in mid-February to regroup, or wait until after the March 4th effort?
I would suggest if the group has capacity to meet one more time before March 4th, just so we can get some more momentum and get, sometimes you gotta reiterate these things a couple of times to get more people to engage with their state representative. I think it's gonna be a really important meeting. So if we are able to meet sometime in February before the March 4th day to kind of put that final push on things, I think it might be really important.
Great. So it sounds like the next step is to send out the stuff, the materials, and then get another meeting on the schedule. And feel free to put in the chat or email. Michael, what's the best email for people to use? We have that president at, if they want to communicate with us in between meetings about anything that's going on.
I think president at primarycareforallamericans.org is a great one. The other question.
Yeah.
The other question is whether everybody would be okay with us creating a listserv, which is often an easier way to communicate. We've learned this from our state work group in Massachusetts, which actually has a listserv of about 300 people. And that is, it's not overwhelming, but it keeps people in touch with what's going on.
I'd say yes, go for it.
Great. We'll get it done.
So let me ask you a question. Who's sponsoring the March teach-in?
That's being put together by the legislature itself.
Okay.
And it's, as I understand it, it'll be supported by an organization called CTC, which has been working to improve the situation for primary care for a long time.
Okay.
Um,
So do the
and-
people from URI have their oar in the water? They're a good source of getting legislators out.
Well, I think that the people from URI are just hoping that the legislature supports the notion of a new medical school.
Okay.
I just wanted to acknowledge as well, Fred Harrington in the chat did say that he agrees with meeting one more time before March 4th.
Michael Bressler? Paul, before we break, do you want to take a second and tell the story you were telling us before about how Blue Cross has made life more difficult for community health centers?
Sure, and I apologize, my baby's in the background crying a little bit, but yeah, I mean, I think just general themes that the insurance companies sometimes are making primary care lives more difficult rather than easy. And so without going into the gory details, we've recently learned that the way that our nurse care management gets paid for has changed up. But for FQHCs, we already get a standard rate for how we get paid for our patients. And so with Blue Cross's changes, it leaves FQHCs without additional funding for paying for nurse care managers. And so it's not just the legislature and other stakeholders that we have to educate, but we also have to educate the insurers on how creating, I think, team-based care and utilizing nurse care managers and nurses and pharmacists and whatnot are important, and they deserve to be reimbursed for the work they do. So, and that ultimately helps, I think, recruit people into the primary care specialties. So I will just say that we are working on it from an FQHC standpoint and advocating that Blue Cross look at its payment models to perhaps restore the funding so that we can adequately pay for our nurse care managers.
I think it's going to be a challenge. You know, the reimbursement thing is part, the workforce and developing a robust workforce with lots of people from all our communities, so that all our communities can have primary care right close to home. That's the opportunity. You know, what we have yet not explained is the way in which primary care is an essential service, like fire protection or police protection, or city water, or even garbage pickup. Primary care is something everybody needs and everybody needs together. And the challenge is to get communities involved in providing primary care to everyone in their community, so that everybody has it. It doesn't happen by itself, but it really can happen. I will just leave everybody with a short story of Situate, which is, as many of you know, the most the Republican town in the state. Situate, Rhode Island has for 25 years been the only place in the United States where everybody's guaranteed access to primary medical and dental care. And that has happened because of a committee of volunteers called the Situate Health Alliance, that has been making this happen for 25 years. And it proves beyond a doubt that, you know, a bunch of dedicated people focused on this very simple thing can really make life better for everyone. So thank you all for joining us. We'll see you in a month. You'll hear from us a bunch. Please call your legislators, and then think about talking to other people in your own community about starting a local work group, because the way to change things at the end of the day is when everybody rolls up their sleeves. You know, what's the great saying? Don't throw up your hands, roll up your sleeves. This is the moment to roll up your sleeves. Thank you all. Thanks a lot to Margaret, and to the leadership group for putting this together. We'll see you all in a month.